I will directly go to my topic because I also have a short time. So on behalf of my department, I am presenting this topic, renal transplantation. It's a big arena, but it's very difficult for me to cover you within this 20 minutes time. I will go fast because I have to give lots of information, but still I know that our audience is PG residents, general surgery residents, so I will stick up to the basic things. So I may be giving you a few details, but I will also give you what are the things you must read. You have to go back to your books and you have to read certain things regarding the renal transplantation. We all know that he is the one who got transplanted in our Hindu mythology, and he is the surgeon. Because we know that the concept of transplantation exists dates back, and still this book from Belly and Love, which is our backbone of our surgical practice, also describes lots of transplantation works being done. Here I would like to tell you something about the definitions. Before going into the transplantation, there are a few things that you must know. Is definition of few of the words. I think you must be knowing these things. The first one is autograft, because when any organs or some tissue is taken from the same individuals and transplanted somewhere else, it is known as the autograft. Isograft is considered the graft which is taken, this transplantation being done between two identical individuals. They are usually the identical twins. Allograft is when the transplantation is done between same species, that from one person to another person, from a Homo sapiens to Homo sapiens is called allograft, and xenograft is from animals. We have been thinking about to produce lots of valves, okay, heart valves from the porcine models, and they are usually considered a xenograft. You should be also be knowing about what is orthotopic transplant and what is heterotrophic transplant, because these are different. When you are putting the organ at the same anatomical space, it is called an orthotopic transplant. If you are doing liver transplant, usually liver are kept at the same anatomical place, so it will be the orthotopic. But the kidney, when you are doing transplant, you are keeping it somewhere else in the retroperitoneal area, in inguinal regions. So they are considered as the heterotopic. I should not emphasize on this slide, because we all know that transplantation is a teamwork and there are lots of involvement from all of the departments. One thing that I would like to highlight is that why this transplantation is technically complex, why the people tell you lots of things about this transplantation, because there are many key factors, issues involved in this. I think one of the most complex things is the surgical technique. Obviously that organ which was harvested from a donor has to be reperfused in the recipient, so it is a challenging topic. Second is that the organ from the donor, from the human product, is not manufactured in the laboratories. It's not like a drugs. So these are really dealt with very caution. Surgeons are really in stress when they are dealing with the very precious organs from the donors. So it's a technically challenge for the surgeons who are doing transplantation. And the most challenging part is the rejection. When you are putting these alloantigens to the recipient's body, this is something antigenics from others' bodies. The defense mechanism always wants to push that organs away. It's called a rejection. So dealing with the rejection is very complex. That's why when you're talking about the transplantations, you have to be seeing all these things: the surgical challenge, preciousness of the organs, and the rejection pattern. We all know that if you go by Love and Belly, they have described very nicely about this rejection process. So what are the antigens, aviole antigens, HLA, all the minus antigens. You also know about HLA, class 1 and class 2 antigens, where they are very specific for the organ transplantations. And these slides must be followed when you are asked about the rejection process. You should be knowing how this interleukin-2 is activate the CD4 T cells, and these antigen-presenting cells in the allografts will help to produce activate the natural killer cells. There will be direct T cells activations, and there will be destruction of tissues, endothelial injuries causing thrombosis, as well as in the long run they form antibody against the antigens. So these are the complex process which always push these organs away from the recipients. And this is the process where the anti-rejection treatments help. We know that when organ is transplanted to the recipient's body, there are 3 types of reactions, which is known as the type of graft rejections, which is known as acute, hyperacute, acute, and chronic. We all know that immediately during the transplantation, if the graft is rejected, that is known as the hyperacute rejections, and it is because of the preformed antibody in the body. But now we have lots of investigations and facilities available to check whether the recipient will have preformed antibody against the antigen which we are going to expose or not. So how to prevent this rejection is very important. When you are asked about these things, so we have to take care of the ABO compatibility. We have to see for the HLA matchings, tissue cross-match, and anti-rejection therapies. These are the key points where the transplant, these anti-rejection therapies need to play. This is one point. This is out of the scope of this my topic, but you should be thorough and you should read about these anti-rejection therapies, immunotherapies, because you may be asked about what are the classification of anti-rejection therapies. So you must be knowing what are the calcium membrane blockers like the cyclophosphamide, tacrolimus. So how does they help in preventing rejections? So they may be asked about this pathogenesis and lots of side effects, common side effects. I think our residents who work with us at teaching hospital, because we have been doing renal transplant for the last 10 years, and they might be knowing about in detail about these drugs, dosage, and side effects. I request other residents also to clear their exams. At least sometimes the external theory, or sometimes they may come up with these anti-rejection therapies, and they might be asking these side effects. So to my topic proper, with this background, so I would like to start about the renal transplantations. And a bit history on the transplant is quite interesting. That the first successful renal transplantation was done by Joseph Murray in Boston, USA, in the year of 1954. So that time one of the identical twins was suffering from CKD, and his brother, identical twins, were allergic to this. It was a Christmas Eve. He was having festivals with the families, and he was called by the hospital. There was a CKD patient was there, and they are going to start a history. They are going to make a history. And the Dr. Joseph Murray did the first successful transplantation. If it had not been the identical twin, he might have rejections. And after that, lots of transplantation has been done, and there was so much of rejections that happened. It's only after 54 years of successful transplantations, it's at Namai Hospital and TBTS in 2008, we started the first successful Retrieval transplant programs, and it is being continued till now, and we have almost completed more than 500 transplants till now with a good success rate. This is a historical picture. I always want to put this is after our first successful transplant at our hospital. So when we're talking about this transplantation, I think there are 3 domains. One is the recipients, because of transplantations, all this story starts with the recipient. Someone is having kidney failure and he needs an organ replaced. There are lots of renal replacement therapies like dialysis, peritoneal dialysis, but I think the best form of renal replacement treatment is kidney transplant, and we all should agree about it. Second, then we need to see for donors from where these organs is retrieved or procured. So thank God we have pair of kidneys in everyone, and I think God has given one extras, so we can share those extra organs. When the near and dear one is suffering from the disease, so anyone can donate. But this all has to be within legal limits. I have discussed a few legal aspects as well during this thing. And the third most part is the technical teams. It depends on the hospitals, and there are surgeons, physicians who are working on this. So who is the ideal recipients? Because we all know that the CKD patients with a stage 4 or 5. Exactly, these are the group of patients. They are already is so compromised that he is not able to maintain his creatinine level, and they are the group of recipients. Residents should know about what is the absolute contraindications for kidney recipients, kidney transplantations, and those recipients contraindication as systemic malignancies, active infections. Although this seropositive HIV hepatitis B was considered as absolute contraindication, but now it's become relative now. So people are doing transplant in HIV patients and hepatitis B positive patients. Non-compliant patient, obviously, if the patient is not committed for the lifelong drug treatment of anti rejection therapy, then he is not a candidate for transplantation. And obviously the substance dependence patient. So on these three associations, I think the donor is the most important part of the kidney transplantations, and we should be very respectful for those donors. And those donors can be live relatives, and those kidneys can be harvested or procured through the cadaveric way. When the patient dies, or as a brain dead conditions, the patient might be in ICUs with ventilatory supports, his heart might be beating, but the patient is no longer survives and is brain death. There are criteria to consider the brain dead, and those can be a good donor for kidneys. And there are patients who are, there are the capital punishment given prisoners who these can be also be the donors in some countries. So basic principle is that the kidney donors should be physically fit. He should be legally acceptable because the legality is different in different countries, and he should be a volunteer. There should not be any pressures or some motives behind the donation. So are there any protocols to consider the evaluation of these donors or criteria called fit donors? Because there are lots of debates, there are lots of criteria are set. One of the criteria is set in Amsterdam in 2004, and it was published in 2005, and this was considered one of the landmark paper in evaluation of the kidney donors. So it is, if you have a time, you can go with this Amsterdam criteria, and you should know about what are the criteria for kidney donors. This is what we never expect. So these are the few of the stories regarding the organ trade, and I think as a surgeons we should always discourage these things. We also might be hearing lots of story about our Oksai village in Nepal. Also people are poor, and these things are happening, but we should be committed against this act. So donor and recipients are evaluated in the hospital in a detailed way, and they all are admitted at least 2 days prior to the operations, and this anti-rejection treatment is started. So when we're talking, I'm not a nephrologist and I'm not opening this topic, but at least you should know that the anti-rejection treatment start with the inductions. So usually they use anti-thymocytic globulin or antibodies like daclizumab for the inductions, and they maintain with the 3 drugs like one is calcineurin inhibitors, cyclosporine or tacrolimus, or anti-proliferative agents like mycophenolate and steroids. So in our hospitals, we have a protocol of 3 drugs. So we give inductions for a few doses, and then we maintain it. Then we also have a final assessment for fitness of anesthesia and the legal perspective. So when we are evaluating the donors for a kidney donor, especially few investigations that I would like to highlight, we should know about the spiral CT renal angiography. When you have a multi-axial, multi-slice CT scans now, it's non-invasive angiography is possible. So we are using CT scan for angiographic evaluation of this patient, because we know that when we are harvesting the kidney and doing the transplant, we are anastomosing renal artery, renal vein, and ureter. So we must be knowing all its detail beforehand, and it's also help us to choosing the donors, which side to take or not. Similarly, we also perform the diuretic renograms, DTPA renogram, to see for the differential function as well. So these are few of the examples of multiple renal artery that actually exist. So I'm going to have one paper. We have already completed 500 donors, and we're coming with the renal artery anomalies and all these things among the Nepalese donors, and this paper is coming in within 6 months' time. Second is multiple renal arteries. When you have such renal arteries, multiples on both sides, it poses a bit surgical technical challenges to us. We all know that in Nepal, we all are practicing this transplantation according to our legal aspects. They are all in Nepal Rajpatra, and this will be published. To be in short, legal has been legalized in Nepal from 2000. There are already law has been passed, but it takes 8 hours for us to try to get a clearance from the ministry. So it's in 2008 we got this legal clearance, and in a teaching hospital we started the transplantation. After that, the same services started at Peer Hospital and Organ Transplant Center. The kidney is retrieved by the open donor nephrectomy or the laparoscopic donor nephrectomy. If anyone asks you which is the gold standard treatment, always it's a laparoscopic donor nephrectomy is the gold standard treatment. But still we are doing open nephrectomy, and hopefully we also march ahead and we will start with this laparoscopic donor nephrectomy quite soon, and that scar can be avoided. Usually it's on a flank position is being done, and the lateral soft coastal incision is given, and we use the extraperitoneal approach is used to harvest the kidney. And preferentially, if the both kidney are suitable, we will take the left side. There are reasons why we choose the left side, because the residents should know. It depends upon the anatomy of the vascularity of the blood drainage from the kidney. Left renal vein is longer. Left renal vein is surrounded by less important structures. So during the dissection, there is less chance of injury to the surrounding structure as well. So it's basically long left renal vein which makes suitable for us to harvest the left side kidney. So one thing that I would like to highlight is while we are doing the dissections, this triangle, which is known as the golden triangle, which is very, very important that you try to preserve this triangle. You should not try to divide the fats and make this ureter devascularized. As you know, the upper part of the ureter gets blood supply from the kidney itself. So this part should not be dissected, and we need to tend this. Why we are keeping the kidney in the inguinal fossa is because that we tend to make this ureter as short as possible. If you tend to keep it long, there is high chance of ischemia and the complications that can happen. So once we remove the kidney to the bench, we call it the bench surgery, then the blood inside the kidney need to be washed. Then the kidney is taken to the ice immersion for hypothermic storage. Now we are doing both the recipient and donor parallelly, so our cold ischemia will not be longer. It will not be more than 15 to 20 minutes. Initially we were using this Urological solution, University of Wisconsin solution for flossing, but now we are using Renal lactate, which is very cheap. These are the few pictures, and in the recipient's operations, I would like to highlight it that when we take the left kidney, we usually keep that kidney to the right iliac fossa. There is reasons. I will tell you why we keep that in the right side. We use the modified Gibson incisions and the inguinal trees, and the extraperitoneal approach is taken, and we always anastomose that renal artery and renal vein to the external iliac artery and external iliac vein. So why we choose that kidney to left kidney, harvested kidney to pass to the right one? So there is anatomical reasons, because we know the relationship between this renal artery and the ureter. So if you go from anterior to posterior, it's an artery, vein and ureter. It's a vein, artery and the ureter. So if you keep that kidney, pass the kidney on the left side, you have to keep passing the same way. So artery will be anterior, vein will be anterior, vessels will be anterior. But when you turn it to the right side, it's the ureter which comes first. Anteriorly we approach the ureter. If you have other complication, ureter complication or stone or anything in the futures, we have always approach from anteriorly, and if you keep on the right side, it's always easy to approach the ureter first. So if you keep it upside down, then there will be a problem. I told you that we anastomose the renal artery to the external iliac artery and renal vein to the external iliac vein. In some books, if you read the books, they always mention that you have to artery should be anastomosed to the internal iliac artery. Yes, many people prefer that internal iliac. They choose the first option as internal iliac arteries. They dissect, ligating one internal, compromising one internal iliac artery is not a problem. But we are doing it to the external iliac. When using, most probably you have been learning the vascular anastomosis technique in CGBS. So there are two ways. Some people are using two suture knot techniques, but now we are using. Initially we used this technique for a few hundred of cases, and then later we changed our practice and we are using the same way the vascular surgeon is doing with the single suture, single knot with the parasuture technique. The retrovesical anastomosis is done with the modified aspirant technique, and it is well described with ureteroneocystostomy. These are two of our pictures of renal transplantations where this renal vein and renal artery is being anastomosed. This is one of the pictures where renal vein is anastomosed with the external iliac vein, and this is the picture after perfusion of the kidney. I will take a few more minutes in the complication because this is also important. So give me a few minutes time because I will just skip slightly. So in renal transplantation, as in other surgeries, the complications are inevitable, and you should be also be knowing about these complications. So there are two parts: donor complications and recipient complications. I won't go into detail about the donor complication because this is same as other nephrectomies, but most of the times some few graded complication like avulsion of renal artery stents can happen, but this can be managed quite well. Urological complications after transplantation is about around less than 5% of cases, and it has the era effect. We all know that. Why there is era effect? Because there are lots of things. We know the better biological behavior, lots of good drugs, surgical techniques, disease states, they have come up. And when you're talking about these complications, I always say that I like to classify three forms. One is the wound-related infections, that is same for everything. Chronic kidney failure patients with the heavily compromised patient, they always tend to have complications like usual. I particularly describe the vascular complications these are the complications that we have encountered in our institute in 500 cases. So renal artery stenosis, renal artery thrombosis, graft rejection, brain thrombosis, these are the three complications that you should be knowing, and you should know how to manage those cases. So these are the few of the pictures of renal artery stenosis, and which was treated after percutaneous transluminal angioplasty with a stent. And few of the urinary complications, as I told you that the ureteric ischemia is one of the important causes, because if you tend to keep the ureter long or you try to fiddle up with this golden triangle, sometimes this ureter gets ischemic, and so the patient can have a urinary leak or a stricture in the later post-operative period. So these are pictures of the few of the patients. We need to divert the kidney, then do antegrade pyelography, and there were lots of ureteric ischemia, necrosis, and that was subsequently managed with Chalise flap. So complications like lymphoria and lymphocyte actually exist, and this is because of the dissection of the lymphatics during the vascular dissections. The complications like hematuria and graft ruptures are also common. The last slide I would like to put forward is the mortality. Still, the transplantation is a very risky game because we are dealing with the CKD patients, and there are lots of comorbidities with the patients. So this is our data is that about 3 to 4% mortality that we encounter during the first 30 days of our post-operative period, and most of the times they die in the post-operative period because of delayed graft functioning with the sepsis, pulmonary embolism, urinary leak, and the sepsis, and the chronic graft rejection as well. So finally, I would like to share these slides for to motivate the organ donations, and thank you so much for giving me your TP. Hope your others want not too lonely. So we also need to encourage ourselves, because now we don't have that policies, government policies to start the voluntary organ donations. We don't have the altruistic donation program because now our legality has only fixed between the close relatives. So we are not giving this kidney to our well-wishers or the friends, but we are only donating to our